Welcome to Brighton and Sussex Medical School's monthly lecture series for February. You will have seen when you came into the room, hopefully, that we are recording this session, and we will be sending the recording out after the talk once we have edited and captioned the talk for people. So my name is Claire Johnson. I work in the admissions team at Brighton and Sussex Medical School, and tonight we're joined by Jessica Eccles, who is one of our academics at Brighton and Sussex Medical School. So Dr Jessica Eccles is a consultant psychiatrist in the Neurodevelopmental Service at Sussex Partnership NHS Foundation Trust, specialising in adult ADHD, autism and Tourette syndrome. Within the service, she co-leads the world's first neurodivergent brain and body clinic, having trained in medicine at the universities of Cambridge and Oxford. She completed integrated academic training in psychiatry at Brighton and Sussex Medical School, where she undertook an MRC clinical research training fellowship. She is now a reader in brain-body medicine at the BSMS Department of Clinical Neuroscience, where she leads prize-winning research on a broad range of projects that link differences in the body to a variety of physical and mental health conditions. She is particularly interested in the emerging link with neurodivergence. She chairs the Neurodevelopmental Psychiatry Special Interest Group of the Royal College of Psychiatrists. She is a passionate educator and committed to public engagement. She hopes to encourage curiosity and challenge stereotypes. So through this, I'm going to hand over to Jessica in just 1 second, but we will be doing question and answer at the end. So please, if you have any questions, do put them into the Q&A box, and we will get to those at the end. Jessica, over to you.
Thank you so much for that introduction, Claire. So I'm just going to share my screen. It may take a second to share properly because PowerPoint's always a bit bizarre. Wait a sec. You seeing that okay?
Yes, we can see that.
Yeah, so I think I'm really lucky. I have a fascinating job. I spend 2 days a week working in the NHS, so Tuesdays and Thursdays, and Mondays and Wednesdays and Fridays I'm at the medical school doing research. And I also do some teaching, and I'm involved in national policy and thinking about autism and ADHD. I'm also a patron of a Sussex-based hypermobility and neurodivergence charity called SEDS Connective, and also ADHD Aware. So I'm using this thing called Slido. So if you go on your phone and either look at the QR code or type in that number, let me know who you are, and as in, you know, what sort of things are you interested in, either at school or university. So interest in science. Well, this is good. I have an interest in science, medicine, behavioral neuroscience, maths, anything medicine related, psychology, genetics, pediatrics, year 12. Well, this is all very exciting. So I hope neuropsychology, biology and chemistry, all sorts of things, cardiology. I hope to pique the interest of lots of you, because this research and clinical work spans so many different areas. How old are you? Someone's just put old. We've got some people in their 50s, but some people who are, 15, 16, 17. That's great. And why would you like to study medicine? This is not the interview. I don't think if you're interested in the money, I would go for another career. Simply a step in the right direction, want to make a difference, be academic challenged. Okay, well, this is all good things. Get to do research, combination of science, human and interactions, learning something interesting. Well, I think the thing I found about medicine is that it's endlessly fascinating, and if you are curious, it is very rewarding. So I'm not expecting you all to know this, and I was the first in my family to go to university, and so I didn't know what it was to go to medical school. But I wonder if you think that undertaking research is part of a medical career. So, I mean, I think it depends on what stage of your career and what type of your career. You absolutely need to be able to understand how to critically appraise research. And so understanding how to critically appraise research best comes from learning how to do research. And in medicine, you can get quite swept up with the training programs. So you've got to get through the foundation program, then you've got to get through speciality training. And you have so many things to do. But when you're a consultant, which is for the, or a GP, which is for the majority of your career, you will not be in training. People have to kind of go into one of three things. They either go into research, teaching, or leadership or management. And I don't think people really explain that well enough when you're doing training. So I think if you've got to do something else, research is a really good thing to be able to do. So what we're going to do is I'm going to tell you a bit about the talk. So I'm going to put out this big idea, which wasn't my idea, it's someone else's. And then I'm going to talk you through a recent paper that we published. And then basically it's like Back to the Future, go back to all of the work that we've been doing that sort of led to that moment. And then hopefully we can have some questions. So the big idea, should we drop the distinction between mental and physical health? The current false distinction holds back research and stigmatizes patients. So how in science or maths do we work out if things are linked to one another scientifically? Beyond chance, because obviously newspapers and things, they're always saying, 20% of people last year had X and 25% of people this year, that must be different. Yes, so we need to do correlation, statistical testing, research and experiments. Yeah, so we do a survey, we do research, and then we have to subject it to analysis. So we're going to talk you through finding patterns. Yeah. I'm going to talk you through this paper. So it was in a special issue of the Proceedings of the Royal Society called Sensing as Being. And what we know is that emotional states are linked to the actual physiology of the body, and that sensing and feeling are inherently coupled. Now, this is a bit of a complicated concept, but there's this idea of something called a bodily prediction error. So the brain is this enormous processing machine. And if the brain were actually to process everything that was happening inside and outside the body all of the time, it would be overwhelmed. So it makes shortcuts. So in order to conserve its energy, it makes predictions about the world. And most of the time, those predictions, so our vision is actually, quite a lot of it is prediction. But when we, sometimes when reality doesn't meet the prediction, this causes some problems. So we can all imagine this in that if we've been walking up or down some stairs and there's suddenly not a step where we thought there was, or there is a step where we thought there should be, there's a kind of physical jolt that we get when we put our foot down. But not only is there a physical jolt, there is a mental jolt. So that mismatch between what's happening, what you think is happening and what's actually happening could be the cause for what we consider to be psychological symptoms. That uncertainty manifests in the brain. So we've got to bear that in mind. And colleagues here have shown that this kind of difference in, difficulties in the internal sense of the body, the prediction error there is related to anxiety and autism. And we designed an interoceptive training to improve anxiety in autism called AD. Now, in the diagnostic criteria for autism, ADHD and Tourette syndrome, there is not really anything about emotion regulation. But emotion regulation is in fact a very key thing. And what we don't know, we often think of these things as neurodivergence, neurotypes, as brain conditions. But actually, there's so much stuff happening in the body. So what we were wondering is, if you are uncertain about where you are in space, proprioceptive imprecision, might that contribute to emotion regulation problems? Now, we talked before about how do we make inference, how do we decide that things are linked? Well, sometimes we do statistics on things and we determine that they're probably related, but we've got more than two things. And so we look into this idea of if three things are related, one of them might be driving the relationship between the other two, and that is called a mediator. A moderator is something which affects the strength and direction of a relationship. So this is something that I've been working on for a while now, a particular condition. Does anyone know what it is? Or anyone sit like that when they were a child, or able to do that yoga pose? Double jointedness, hypermobility. Yes. It is indeed hypermobility. And hypermobility is part of EDS. So all people with EDS have Ehlers-Danlos syndrome. Not all people with hypermobility have Ehlers-Danlos syndrome. So yeah, I think we're getting the picture. Hypermobility. Does anyone know of any conditions, medical conditions or things that go with hypermobility? Autism, arthritis, joint pain, chronic pain, EDS, yes, osteoporosis, dyspraxia, POTS, digestion difficulties. Well, I think you actually are more informed than a lot of the doctors that I talk to. Recurrent dislocations, digestion difficulties, easy bruising, absolutely. Allergies, so many things. Any connective tissue issues, quite right. ADHD, POTS. Now, it's interesting that you highlight those as the biggest ones. They're very only recently been determined to be associated, but we'll go through that. So this is this paper that we had published this year, 15th of July, by the looks of things. Emotional feelings are putatively ascribed to the central representation of bodily states in the concept of expectation and uncertainty. Neurodivergent people, so autism, ADHD, Tourette's, etc., are more likely to experience co-occurring mental health challenges, although mechanistic insights underpinning this association are scarce. We therefore undertook a study to test whether imprecise processing of proprioceptive signals may underlie the connection between neurodivergence and emotional dysregulation. In a cohort of people with complex chronic conditions, including chronic pain, fatigue, and complex trauma, and in a comparison group, we assessed for the presence of neurodivergence, hypermobility, and emotional dysregulation. We present a data-informed model showing that variant connective tissue determines whether proprioceptive supplies is linked with emotional dysregulation in neurodivergent individuals. We suggest that future research in this area may have important clinical implications for the interaction of mental and physical well-being in neurodivergent people. So what we did is we used a screening questionnaire. This was all online for hypermobility. We used a dissociation measure for emotion dysregulation. We used the RADS and the Wender-Utah for neurodivergent characteristics, and we calculated proprioceptive surprise from the Glasgow Sensory Questionnaire. And I'm not expecting you to understand all of this, but these are R values, which are correlation coefficients, and they're all highly correlated. And what we do is we put this in the mediation and moderation model, and neurodivergence is linked to emotion regulation problems as a consequence of proprioceptive surprise. That is the mediator, that is the mechanism, But you can see that that relationship is twice as strong if you have joint hypermobility. So this is an integrated moderation mediation model demonstrating the moderating role of hypermobility on the mediating effects of proprioception on the relationship between neurodivergence and emotion regulation. It's a bit of a mouthful, but it basically is suggesting that this is a brain-body thing. So, can you now, or could you ever place your hands flat on the floor without bending your knees? Can you now, or could you ever bend your thumb to touch your forearm? As a child, did you amuse your friends by contorting your body into strange shapes, or could you do the splits? As a child or teenager, did your shoulder or kneecap dislocate on more than one occasion? Do you consider yourself double jointed? Add them up. What is your score on the 5PQ? Less than 2 or 2 or more? This is interesting. You are, of course, probably relatively young, but we would expect, because we know this from young people, that probably only 20% of people in general score 2 or more on this questionnaire. I think it misses out hypermobile men, but this is another topic. So you seem to actually recognize hypermobility, which is brilliant. Hypermobility is a variation in connective tissue. So things like collagen, not just collagen, but all sorts of things, elastin. And hypermobility is, I think, the flexible joints are a bit of a red herring. It is common, affects about 1 in 5 people, and many of you, and it can be advantageous. So people like Simone Biles, Michael Phelps, both hypermobile and have ADHD. It's linked to a variety of medical issues, and these issues cross systems and involve both the body and brain. And it really has been, I think, one of the reasons why hypermobility is not well understood in medicine is the alphabet soup. There are so many different terms, some of them outdated, some of them not, to describe hypermobility, and you pretty much need a degree, a PhD in hypermobility to tease them all apart. But this is symptomatic hypermobility from a slide from many years ago when I was doing my PhD, but you can see all of these medical things that are associated with hypermobility. Flat feet, soft velvety skin, stretch marks, easy bruising, resistance to local anesthetics, pretty much every gastro problem, including inflammatory bowel disease and irritable bowel syndrome, mitral valve prolapse, Raynaud's phenomenon, irritable bladder, short-sightedness, squints, dental problems, temporomandibular joint pain. And then where I've got interested, this thing called dysautonomia. So the autonomic nervous system is the involuntary nervous system. Dysautonomia is problems with the involuntary nervous system. Clumsiness, proprioceptive dysfunction, paresthesia, which is, tingling and stuff, headache, fatigue, sleep disturbance. I don't think it's cognitive impairment. I think it's brain fog, anxiety, hyperesthesia, so sensitivity to pain, hyperosmia, sensitivity to smell, and hyperacusis. Have you heard of POTS? Postural tachycardia syndrome. Blimey. Yes, much more so than most of my medical colleagues. I wonder where you've heard about it. I'll have to ask that question next time. But this is very encouraging. So postural tachycardia syndrome, the name is actually in the title, is a fast heart rate on standing. And this is typically 30 beats per minute from supine to upright, so from lying to standing. We can test for it on a tilt table or with an active stand test. And it's very closely linked to hypermobility. So about 80% of people with symptomatic hypermobility have POTS, and about 90% of people with POTS have some form of hypermobility. And we're wondering, why might this be? Now, POTS is a complex multifactorial condition, but you can imagine if you've got floppy connective tissue You have that in the vasculature, so around the veins and arteries. And so if you go from lying to standing, you have less blood returning to the heart. In order to maintain perfusion, you have to raise your heart rate. So when the autonomic nervous system works differently, mental health problems are more likely to develop or be diagnosed. So in a room with 100 people who experience panic attacks, how many of them are likely to be hypermobile? I sort of cheated here in that the exact answer is not covered. It's nearly 70%, whereas only 20% in the general population. So hypermobility, we've known a lot about hypermobility and anxiety for a while. And this I just thought was quite interesting. It was a paper that I read when I was doing my PhD. It looked at students, I think, and found that hypermobile students were more likely to consume chocolate, coffee, cigarettes, and alcohol. And the frequency of chocolate intake was significantly higher. So they're saying this might be an attempt to self-medicate anxiety, but I wonder now, with what we know now, which we didn't know in 2011, whether it might be self-medicating something else. So I did my PhD. So I did, Claire mentioned I did an MRC PhD, which means I got paid to do a clinical salary, doctor salary to do a PhD after I had done the first part of my psychiatric training. And I spent my time working out how you get from having flexible joints to being more likely to have a panic attack. The first thing we ever did, this was before the PhD, is we published a study, brain imaging study, where we showed that people with hypermobility had larger amygdala, which is involved in fear and emotion processing. We also saw some similarities to do with autism. And a part of the brain that's involved in where we are in space was smaller. So this proprioception was smaller in people with the more hypermobile joints you had. So we also looked at the Alphabet birth cohort, and we found that if you were hypermobile at 14, 15, you were more likely to experience depression and anxiety at 18. And we just have published yesterday, or maybe the day before, this paper, which was actually data from my PhD. But we basically, this was a functional brain imaging study showing hypermobile participants had weaker neural reactivity to emotional phases in the frontal area of the brain, and that hypermobility and anxiety was expressed in the reactivity of left amygdala, mid-insular, which is primary interoceptive, so the inner sense of what's happening in your body, and severity of hypermobility in anxious compared to non-anxious individuals correlated with activity within anterior insula. So the predisposition to anxiety in people with variant connective tissue reflects dynamic interactions between neural centers processing threat and representing bodily state. We have another paper that's been pre-printed that is another one of these bodily prediction errors, and we talk about autonomic perceptual mismatch. And we find that autonomic perceptual mismatch correlates with enhanced activation in emotion processing and autonomic regions, and anxious individuals exhibited increased mid-insular cortex activity, and activity was decreased within the inferior frontal region, a region implicated in cognitive control. So this is a big thank you to my students, Poppy and Christina, and my dear colleagues, Dr. Charlotte Ray, Prof. Sarah Garfinkel, and Prof. Hugo Critchley. Prof. Critchley was my PhD supervisor. And the cool thing about all of these photos is they were taken whilst on conferences. So one reason to be an academic is you get to go on conferences. So we turned the autonomic perceptual mismatch data into a novel body-based treatment for hypermobility and anxiety called ADAPT, and that was my MQ fellowship. And really, working in hypermobility has been a series of light bulb moments over the years. And patients do write to me and they say, oh, it's a light bulb moment. I heard your talk and blah, blah, blah. But it really is a way of connecting the dots. So Harriet Sharp, academic clinical fellow. So that's when you combine your speciality training with training in research. I did that. Harriet wrote Connecting Brain and Body, Transdiagnostic Relevance of Connective Tissue Variants to Neuropsychiatric Symptom Expression. And Jenny Chich helped us put together this paper about joint hypermobility and dysautonomia are associated. So dysautonomia is POTS with multimorbidity at the intersection between physical and psychological health. Back to that original paper, which, as I said, had the proprioceptive stuff, but it also had autism. So we were thinking right from the beginning, are hypermobility, autism, and ADHD linked? So what do we know about neurodevelopmental conditions? When I was at medical school, which was a long time ago, probably in 2003, I was told that autism affected 9 times as many boys as girls. We know that gender stereotypes are complex and a challenge, that neurodivergence is not just boys, bus timetables and fidgeting, and that many key elements are not captured well by the diagnostic criteria. And there are some myths and stereotypes about empathy, theory of mind, communication, and that in ADHD, there's actually variable attention, and also, as I mentioned before, the role of emotion dysregulation, and that co-occurrence is the norm, both with other neurodevelopmental conditions and certain physical health issues. And I do believe the language we use is important. So I'm not going to dwell on that, but that's my approach to a neurodevelopmental assessment. So this shows that if you give school teachers vignettes and you put girls' names on them instead of boys' names, they're less likely to refer them on with the exact same vignette for an autism assessment. But we know that probably the sex ratio in autism is likely 1-on-1. We also know that there are significant barriers to healthcare and adverse outcomes for neurodivergent people, and that there are a lot of commonalities between ADHD and autism and Tourette's and hypermobility. So dysautonomia, the POTS is present, pain, developmental coordination disorder, anxiety. Case control studies in children showed a link between ADHD and dyspraxia. So, how likely is autism if you have symptomatic hypermobility? You don't have to know. You can put not sure, I think, or you can just well, quite a few of you think you know, which is great. So this is data from the whole population of Sweden, where they keep really good health registries. If you have a hypermobility diagnosis, you are 7 times more likely to have an autism diagnosis, 5 times more likely to have an ADHD diagnosis, 3 times more likely to have a bipolar diagnosis, and unfortunately twice as likely to have attempted suicide. So these are only the people who are diagnosed. So imagine if we had better screening and diagnosis. So people have been looking at ADHD and autism and pain and hypermobility. In 2022, we published this research study, Joint Hypermobility Links Neurodivergence to Dysautonomia and Pain. And what we've showed was if you, and this was done in Sussex in our Neurodevelopmental Service as part of my PhD, and we showed that you're 4 times more likely to have hypermobility if you were neurodivergent, and you're more likely to have musculoskeletal symptoms and orthostatic intolerance symptoms. And if we look here at the pink, nearly 80% ADHD and autism females with hypermobility, and that the hypermobility score tracks with the orthostatic intolerance and the musculoskeletal symptoms. So going back to these mediators and moderators, we put this all together, and neurodivergence is associated with physical symptoms because of hypermobility. So we've continued this work. I got into, Professor Davis introduced me to the relationship between hypermobility and fibromyalgia. We did a study where we were looking to see what the biological mechanisms of pain and fatigue could be in fibromyalgia and ME/CFS. We brought people into the hospital for a tilt table challenge. We brought people to the brain imaging centre. They came twice. They had an inflammatory challenge, and which was a typhoid vaccination. We found that although the patients either had a diagnosis of fibromyalgia or ME/CFS, they probably both met diagnostic criteria for both. But actually, 4/5 of them had symptomatic hypermobility, and hypermobility predicted fatigue, pain, and all sorts of things. We also showed that the patients had slightly raised levels of inflammation, and that predicted pain and fatigue. And we put them on the tilt table, and what you can see in the red is the patients having pain induced by tilt and also fatigue induced by tilt. We put this all together, and being a patient is related to tilt-induced pain because of hypermobility. Being a patient is related to tilt-induced fatigue because of inflammation. We brought them into the brain imaging scanner. We brought them into the brain scanner, and we gave them the inflammatory challenge. Now, we were interested in this thing called arachnodactyly, which is one of the hypermobility features. So it's where you can overlap your thumb and your little finger at the narrowest point of your wrist, or protrude your thumb the other side of your palm. And what we found was that if you were a patient, in response to the inflammatory challenge, you had inflammation-induced pain and fatigue because of your inflammatory responsivity, but that relationship was only present if you had arachnodactyly. We looked at brain imaging, and we found that the inflammatory challenge changed the connected nature of the brain in some people, and that was related to the number of hypermobility features, and that the change in that connection, the modularity, was associated with a change in symptoms because of the number of hypermobility features. Now, that is a lot of work that we were doing, and I have to say a massive thank you to loads of people, but particularly Hugo Critchley and Kevin Davis. We've been doing work that was published this year in terms of hypermobility being linked to long COVID, and that was featured in The Guardian. So we found that hypermobility didn't mean you were more likely to catch COVID or come down with COVID, but you can see that the COVID non-recovered had a higher proportion of hypermobility than the COVID recovered. We put this all together, and we control for things like age, sex, ethnicity, socioeconomic status, education level, vaccination status, number of vaccinations. This association remains significant. So 30% more likely to not recover from COVID. So individuals with joint hypermobility, more likely not to have recovered, is clinically important through its potential impact for understanding and identifying subphenotypes of long COVID for screening and personalised targeted interventions. More generally, greater awareness of hypermobility and its non-joint associations is needed for effective patient stratification and implementation of personalised medicine. So, how is autism and ADHD and other things related to chronic pain and fatigue? Well, we went back into the ALSPAC study, and we found that children with neurodivergent traits at 7 and 9, twice as likely to experience chronic disabling fatigue at 18, and that this was related to their level of inflammation at age 9. So what we've also done is we've looked at the relationship between hypermobility, fibromyalgia, ME/CFS, and neurodivergence, and lo and behold, neurodivergence is associated with the presence of chronic pain and fatigue because of hypermobility, and this is under review at the moment. Why is it important to think body-brain? Well, nearly half of neurodivergent individuals feel that their treatment of mental or physical health symptoms is worse because they're neurodivergent. Our own involvement work tells us that neurodivergent people struggle for years to get an assessment and diagnosis for both mental and physical health problems. They feel a strong sense of being dismissed, misbelieved, or overlooked when interacting with professionals and institutions, and they repeatedly encounter poor understanding and few or no adjustments for their needs within healthcare and education settings. So this is just some work that was published just a couple of, well, just before Christmas. We looked at first episode psychosis in our mental health trust and determined that 40% of them were likely neurodivergent, and that unfortunately the neurodivergent patients with first episode psychosis had a more frequent use of mental health services, a admission length of twice as long, and interestingly, an onset of psychosis 9 years earlier. And Dr. Helen Matthews said, spot on, this is what is needed to enhance the evidence base to influence policy and practice. And a member of the public said, I'm so glad this research is being done. So that was Nick Nicolak. He's now just got a very prestigious, he's a pharmacist working in the early intervention and psychosis service, and he has a very prestigious NIHR grant to take this further. Our medical student, Emily Buckmill, has prepared this paper for publication. It's currently under review with the BJ Psych. We show a relationship between hypermobility, neurodivergence, and bipolar. Nearly 80% of the bipolar patients are likely autistic, nearly 70% likely ADHD. We put all of this together. Remember from the Swedish study, hypermobility was linked to bipolar. So hypermobility linked to bipolar because of neurodivergence. We're just, Pediatrics ACF ISRA is just putting together this piece of work showing the relationship between autism, eating disorder, ADHD, and hypermobility all at once. And we're just starting on this piece of work about neurodivergence, hypermobility, and self-harm. So bringing us back to the first paper, conventional emotional medication-based treatments do not work for all. Most psychiatric drugs are grim and have horrible side effects. I mean, not all of them. And not everybody benefits from things like CBT. So the idea is that interventions like the one I described, you know, the research that I showed you about how neurodivergence was related to emotion regulation because of proprioceptive uncertainty in the presence of hypermobility, that basically means that maybe we should try proprioceptive training as a means of improving emotion regulation. So the trauma is real. Patients, hypermobile patients, frequently overlooked and takes years to get a diagnosis and often gaslit. So you've got to be careful of not becoming one of those doctors. What might be the advantages of hypermobility or neurodivergence? Varied worldview, academic or sports, cool party tricks, new perspectives, greater understanding, increased empathy, a different perspective, hyperfocus, impress friends, cognitive flexibility, ability to do gymnastics. Diversity is good. Absolutely, can draw ideas together, intense interests, can empathize, attentive. Brilliant. So I want to talk to you a bit about the research that we've been doing about strengths. So I was approached by a film director a couple of years ago who wanted to make a documentary about hypermobility, neurodivergence, and creativity. And we looked in 250 people in the general population, and we found that hypermobility was associated with measures of creativity because of neurodivergence. And then my medical student, Ben, he did a fabulous piece of work he did a fabulous piece of work which is now under review, exploring the relationship between neurodivergence and creativity, finding that creativity for neurodivergent people was a form of expression, a means of communication and hyperfocus, a form of resilience against isolation and improving emotion regulation, and a form of empowerment, a way of thinking differently and finding value. So we've got some exciting projects going on at the moment. We've got the neural correlates of brain fog. So we induce orthostatic intolerance in the brain scanner. You can't put a tilt table in the brain scanner, but we use a lower body negative pressure chamber. James Todd is working with flotation tanks to see if that improves fatigue through sensory deprivation. Beverly is our PhD student looking at brain fog in pregnancy and the menopause. Isra is our ACF, who is looking at the link between neurodivergence allergy and neurodivergence hypermobility and eating disorders. Dr. Salucci Amobi is looking at the link between autism, ARFID, and food allergy. Evelyn Crosskeys is doing neurodiversity affirmative autism assessment research. And Esme Morecambe is going to be looking at the interoception data on the inflammatory challenge. Jemima has taken the bipolar data a whole level further. Andrea is going to be looking specifically at creativity, hypermobility, and neurodivergence in dancers. And Ben is looking at stigmatizing language around autism. So, would you consider a clinical academic career in medicine? I have to say it's really most fun. But I did always like maths. Well, I think it's one of the most rewarding elements, and obviously getting to do teaching and stuff as well is brilliant. Ooh. What have you learnt this evening? You don't have to have learnt anything, but please do put down if you have learnt anything. Oh, yeah. Brighten attracts bright people. I like that. Thank you. It does. Yeah, exactly. Autism is a whole body thing. Everything is connected. So it looks like lots of things. So it is really rewarding and stimulating being a clinical research career. I mean, I think it's one of the most stimulating things that I do. Every day is different. So Monday I'm here, Tuesday I'm in clinic, Wednesday I'm here, Thursday I'm in clinic, Friday I'm here. Every day is different. And I have such wonderful colleagues and mentors and amazing people. But I do think we're in a bit of a bubble. And really doing some interesting stuff that I'm not sure the world is quite yet ready to understand. But it is wonderful to both have a clinical role and an academic role at the same time. Yeah, no, I mean, pretty much hypermobility and neurodivergence seem to be related to almost everything. Yeah, brain body, mustn't forget the brain body. Well, thank you all so much for being so active in the Slido. It makes a real difference when I can't interact with you. So I'm just going to say a huge thank you. I know I put up some slides to say thank you to people, but I must say a massive thank you to my colleague Lisa Quat, to my mentor and all-round inspiration for these things, Prof. Hugo Critchley, and for the creativity work to Nigel Colt. Thank you very much, and I will stop sharing and go to questions. But I just wanted to say, you can follow me on I am on various media things. So I'm on X and Blue Sky as Bendy Brain, Instagram as Dr. Bendy Brain. I have something called a link tree, which I'll put in the chat in just a second, which has loads of links to talks and things that I've done. So I'm just going to stop sharing, and I don't know how we take the questions.
Hi, Jessica. There's people have put in some questions into the Q&A, which you might be able to pull up, but I will read them out as well. So the first one we've had in is, hi, do you think an EPQ on lucid dreaming as a therapeutic tool in treating psychological problems is good for medicine? So an EPQ is like an equivalent to half an A level.
Oh, do I think will it help with getting into medical school?
Potentially, yes. I think that's what they're going for.
I think, Claire, I best direct that question to you in the
Yeah, okay. So I can answer that. I'll type an answer into that one while we were chatting. So someone else has been asking whether they can get access to some of the papers that you've highlighted.
I'm just gonna put something in the chat. There, everything is there.
Perfect.
Well, not. I mean, some of my earliest work isn't that, but it is in the papers front, but not all the videos. Where's the chat? So I'm just going to put this in the chat. So please do check out Linktree Bendy Brain, and there you'll see the full publication list. Oh, that's just to host some panelists. I need to send it to someone else.
I've just put it into everyone for you. Don't worry. Thank you. So the next one is, what are proprioceptors?
What is proprioception? Proprioception is the one of the senses. So it's not like sound or smell. It's the sense of where you are in space, as in your body's sense in space. So proprioceptive uncertainty, which is what we were talking about, is an uncertainty about where you are in space. Okay. Highly linked to what used to be called dyspraxia, which is now called developmental coordination disorder.
Brilliant. Thank you. So the next one is, where is the best websites and medical journals, research, etc., for medicine research that is very accurate?
PubMed.
PubMed. Okay, perfect. Next one. If you experience some of the symptoms you mentioned, would it be worth getting tested for autism, ADHD, etc.?
It may well be worth having a discussion with your GP. Absolutely.
Perfect. Someone has asked, was bipolar distinguished from PMDD?
The people, we didn't query about premenstrual. We didn't specifically ask about PMDD, but they had to have a clinical diagnosis of bipolar to be in the study. You see, that was just a sort of an initial study. A future study would really try and tease apart the intersection of all of these things. It might be that some of the people who have bipolar were misdiagnosed, underdiagnosed, overdiagnosed. It's hard to tell. But there's really, I mean, one area of medicine that is woefully under-researched is anything affecting women exclusively. So PMDD, adenomyosis, endometriosis, menopause, pregnancy, all really, under considered. So we absolutely need to look at PMDD, particularly because we find that a lot of patients, both neurodivergent and hypermobile, have a worsening of both physical health symptoms and mental health symptoms in that phase just before the period. So in our ADHD follow-ups, we sometimes suggest that people take additional ADHD medicine in those 2 weeks before their period.
Perfect, thank you. The next question is, what made you and your team interested in this particular topic?
Well, that's an interesting one. So when I was at medical school many years ago, so we were probably talking about 2005 maybe, I was on an orthopedics rotation, and a doctor came up to me and said, you have sway back knees, i.e. you are hypermobile, have hypermobility syndrome, come and see me in clinic. So I went to see him in clinic. He was called Dr. Althwaite. This was in Oxford, and I went to see him, and at the time I was struggling a lot at medical school because I had arthritis, or from a problem. You know, all newborn babies are checked for this clicky hip business. Well, I had a particularly bad case of developmental dysplasia of the hip, and by the time I was at medical school, it was quite hard to walk around. So he sent me on a pain rehabilitation course, which I did instead of a special study module. But I didn't think too much more about it. I then came to Brighton to do my foundation jobs, and I had a bit of a rough time in terms of walking around the hospital. Had to have some adaptations to my job plan because to avoid having to do these incredibly epic medical ward rounds. Surgical ward rounds were a bit shorter. Anyway, when I had finished foundation program training, I started an academic clinical fellowship in Cambridge because I thought at the time I'd done an integrated degree when I was an undergraduate in the history and philosophy of science. And I thought I wanted to study something called epistemology, which is the nature of knowing. How do we know what we know? And so I went off to do an academic clinical fellowship in Cambridge to work with a particular philosopher. And but the program didn't work out at all. I didn't get any protected time for research. The clinical work was hellish. So I resigned from that job, and I took up an academic clinical fellowship back here in Brighton, which I very much liked from being at foundation school. And when I went to see Hugo, who was the professor of psychiatry, and he'd just come, Brighton and Sussex Medical School had only recently been set up, and he'd just set up the brain imaging centre. I went to talk to him about projects, and he said, "Have you heard about hypermobility?" And I said, "Oh, I have actually. I think I've got it." Well, no, I've got it. And he said, "I want you to find out if all of those, from all the brain scans that have already been taken place in the brain scanning centre, whether they're hypermobile or not." And that was the start of that first paper, which kind of led everything off. Sorry, that was a very long explanation.
Thank you. So did you always plan to go into research, the more clinical side of medicine, or did this evolve over your career?
I very much enjoyed my intercalated degree at medical school, and I thought I liked that variety. And then I was in Oxford, a medical school in Oxford, and they had advertised something called the Academic Foundation Programme. And I thought, well, I don't really have a chance of getting onto that because, you know, I was surrounded by people who'd done, every single person had done an integrated degree and, you know, was super keen. But when I came to Brighton, they advertised for the Academic Foundation Programme, and I got on that, and I really enjoyed that. And that gave me a structure and a pathway to get onto the integrated academic training programme to be an academic clinical fellow. And then after I did my PhD, I became a clinical lecturer, and then I got a permanent job at the medical school. So I think I was always interested in research. I think when I was first looking at medical school programs, I was quite interested in the Imperial one, I think, because you could do a PhD whilst you were at medical school. I don't think it's wise to do a PhD whilst you're at medical school because you don't get paid properly. But I think I was always interested in finding things out. And as I said, I very much like maths, and there is nothing more pleasing to me than a statistical output where you suddenly see that everything is connected.
Perfect. Thank you. So can hypermobility develop as something like anxiety develops over one's life?
Well, this is a very interesting question. Before COVID, I would have said, no, you're born hypermobile. And that's it. You just get less hypermobile as you get older. But what we think is actually maybe some inflammatory challenges, like maybe COVID, they can make a hypermobile person have symptoms when they didn't have symptoms before. So that's definitely true. But I think hypermobility is a developmental factor, whereas anxiety comes about at different stages in the life. You're not born typically anxious, but we can't really interrogate children in the right way, can we, to work out if they're anxious or not? But I think the hypermobility comes first.
Perfect, thank you. So how can hypermobility related traits like flexibility and increased joint mobility influence motor skills and coordination in children with ADHD or autism?
Well, I think they probably need some proprioceptive training, balance board, wobble board, therabands, that sort of thing. I think it can be really, it could be helpful to have proprioceptive training.
Okay. How does this differ course in medicine to neuropsychology? Struggling to understand that question a little bit. So,
how is this different in medicine to neuropsychology?
Yes. How does this course differ in medicine to neuropsychology? Yes.
Okay, so medicine is a medical degree which covers all elements of the body and the brain, and gives you the ability to diagnose and prescribe. Neuropsychology is the preserve of psychologists. Psychologists are people who have done a psychology degree and then gone on to do a DClin in psychology, so an equally long program to medicine. They cannot diagnose and they cannot prescribe, but they can evaluate someone's intelligence or their cognitive profile, and they can work as part of a multidisciplinary team in a psychiatric setting or in a rehab setting. Most neuropsychologists are doing stuff about strokes and brain injury. If you want to become a neuropsychologist, to become a psychiatrist / psychologist is quite an important question. Do I want to be a psychiatrist versus do I want to be a psychologist? Studying psychology at university is nothing like being a psychologist. I would recommend going and shadowing a neuropsychologist in order to see what it is that they do every day. But a psychiatrist, the great thing about being a psychiatrist, which is having studied medicine, is that you can be interested in psychology. You can even be a medical psychotherapist, but you've got a really broad remit, and you get to prescribe and you get to diagnose.
Perfect, thank you. So how can you get involved with research as a neurodivergent medical student?
Well, at BSMS, we have a number of programs that enable medical students to get into research. You may have noticed some of the papers that I presented in the work I showed you have been done or contributed to by our medical students. So that was Ben Erin, Jemima, Jacob Porter, and Emily Bucknell. And they're all people who've worked with me as medical students. So there's two things. So at some point before your final year, you can do, so best after third or fourth year, you can do a whole summer as a junior research associate. So you get paid to do that. In fourth year, you have to do an individual research project, which means that you do research for 1 day a week. And then medical school is pretty heavy going. There isn't much more things that can be done outside the timetable, but many students intercalate, well, not many, some students intercalate between third and fourth or fourth and fifth, and they go and do a master's or another or the final year of another course, and that may have a research component. I particularly like working with medical students who have done intercalated degrees.
Cool. Someone has asked, would topics similar to this and so up to date be covered in BSMS during your years at medical school?
Yes. So I teach similar things at a number of points at BSMS curriculum. So For the second years in neuroscience, we do a neurodiversity symposium. For the fourth years, so for the third years, I provide clinic placement opportunities for their psychiatric rotation. Fourth years, some of this information goes into the Time for Autism program. And also I give a lecture for rheumatology on chronic pain. And then I also teach the year 5 psychiatry placement students also come to my clinic. So there are opportunities to learn about this sort of thing at BSMS.
So this will be the final question because I'm just conscious of time. So how do you think this research will change medicine in practice?
I think it's huge. I think understanding that the brain and the body are linked and that lots of these complicated conditions that we hadn't really got to the bottom of are in fact hypermobility and neurodivergence. I think it is a real paradigm shift in how we think about common problems.
Perfect. Thank you so much, Jessica. We've had so many questions. There's just no way we can get through them all. So thank you very much for being active participants in this talk with the Slido with Jessica and putting in the questions as well. We really appreciate it because it makes these talks go a lot easier, definitely. So thank you very much. I will be sending out a copy of this recording in probably in about a week's time once, like I said, I've captioned and edited it. But you saw Jessica's contact details there, and also you can get in contact with us at outreach@bsms.ac.uk if you had any other questions. But thank you so much and enjoy the rest of your evening, and I will now be closing down this talk. There's lots of thank yous coming through, Jessica, as well.